مساء الخير جميعا. بس أتأكد كالعادة إنه صوتي واصلكم ولا لا. if you can please send me a comment, I'll be grateful. Hello, can you hear me or not yet? Brilliant. Okay, so everybody can hear me. So we'll wait just a couple of minutes for people to start coming in. Okay, مساء الخير جميعا. Good evening and welcome to the second part of the talk about MIH. And if you have a question, just like yesterday, can you please keep it to the end, because I'm not won't be able to see those questions until the very end. Well, today I decided to go with a more casual look, as you can see. Before I start, I just want to talk to the students who attend the literature review sessions with me. So next time it will be about intracoronal restorations for the primary dentitions. I'll be sending out the articles inshallah soon, probably by Friday. So be prepared for the session. Anyway, let's start part two of this talk. And today, just like last time, we will dive into a few aspects of this condition. Yesterday, we reached the stage we were talking about those motor defects. So what do we do when we have cuspal involvement, or when we have extensive post-eruptive breakdown, or if our tooth received some sort of endodontic treatment? Well, in that case, we have no option but to use extracoronal restorations, such as stainless steel crowns or cast restorations. Talking about stainless steel crowns first, it's usually the pediatric dentist's first choice for many reasons. I'll come to that in a minute. But the advantages is the fact that it does not really need lab work, so it's done in in the same visit, more or less, and unfortunately, it's not a permanent solution because, as we know, that the stainless steel crown is not strong enough to last the child a life long. It will wear through as a child grows up, so it will need to be replaced later on with a more permanent restoration. A tip that I can give you from experience is that if you can place separating elastics a week before you do the actual work, that will open the contacts and will make it so much easier for you to prepare the crowns. So separating elastics a few days a week before the preparation will make it much easier for you. Um, the alternative would be obviously cast crowns, but we'll come to that in a minute. First, an older study, 1990, that looked at the success rate of those stainless steel crowns. It compared the success rate of stainless steel crowns to amalgam fillings after a follow-up of 10 years. And they found out that while the failure rate of amalgam is low, 11%, the failure rate of stainless steel crowns is even lower, 2%. This is not for MIH in particular, but for many cases, for any tooth that did receive, any molar that receives stainless steel crown in children. So stainless steel crowns are quite successful in permanent molars. So after the endodontic treatment that Iman received in her upper six, our endodontist put cuspal coverage with amalgam, and that is the standard of care at Otago, where the endodontist has to cover the cusps in order to prevent them from fracturing until the dentist can do the full cuspal coverage. So Iman came to us in this looking like that, and we had the option of either placing a stainless steel crown or cast gold restoration. And because Iman was quite older, 16, almost 17, we decided to go ahead with gold crowns. And our technician did a wonderful job, and this was the end result. We know from research, especially an article in 2003, that stainless steel crowns and gold crowns or onlays have a very similar success rate. These gold crowns have the advantage of being permanent and not needing any replacement, but it does really require more cooperation from the child, because there is the impression step and the cementation, the try-in. So there are a few steps that are more than the stainless steel crown, but it, on the other hand, requires less work, less preparation. While the stainless steel crown does probably need a little bit more preparation, but on the other hand, it's faster and it does not really require lab work. I got a few questions yesterday about resin infiltration, whether it works or not, and those were good questions because I was going to address this topic today. And resin restorations, for those of you who do not know, it refers to a particular brand called Ikon. It's out of DMG, which is the German company that mainly manufactures rubber dam. And Ikon is basically an unfilled resin that can infiltrate into demineralized and airly carious enamel. So it works, or it was originally developed to work on demineralized enamel, airly carious enamel, to infiltrate it after treatment with hydrochloric acid, and with the hope of stopping the caries from progressing. The concern here with MIH enamel is the protein, just like it was our concern with CPP, ACP. The concern is that this excess protein could prevent Ikon from infiltrating into this hypomineralized enamel. So a good friend of mine, Arun, did his doctorate research looking at the infiltration into MIH enamel with Ikon. And he had different procedures where he tried to see if Ikon can penetrate on its own, or if pre-treatment with sodium hypochlorite or pre-treatment with hydrogen peroxide to remove the surface protein would allow better penetration. And he published a couple of studies on that. And in summary, his Raman spectroscopy found that there could be no resin penetration into MIH enamel, at least not to a predictable degree, if not treated with a deproteinizing agent. However, when he used, well, his explanation was that excess protein would prevent the penetration, but when he used hydrogen peroxide and sodium hypochlorite, he noticed better penetration. Still not completely predictable, but better than using nothing. And he noticed that if we used hydrogen peroxide rather than sodium hypochlorite, the penetration of Ikon was better. Hydrogen peroxide for some reason worked better than sodium hypochlorite, which in turn works better than nothing. So yeah, probably pre-treatment before Ikon with hydrogen peroxide would give us better results. We know that, or we've noticed that a lot of our decisions are based on the severity of MIH. In other words, how severe MIH can dictate our treatment approach. But how can we tell how severe this MIH is? Is there a way to say that this case is going to break down probably, or this case will not survive that long? It's really hard. And we thought about how about the color? We know that MIH enamel is discolored. Does brown colored enamel give us an indication that it will be weaker? Is brown weaker than yellow? Is yellow weaker than chalky white? Is there another method? So we looked into that, and a study we did in 2010 looked at the different colors of MIH enamel, because this is what we can see. And we found that the darker the enamel, the weaker it is, the less minerals it has. So brown enamel is weaker than yellow, which in turn weaker than chalky white, and they're all weaker than sound enamel. Another thing that we can use is Diagnosing. And Diagnosing is a machine or a device that we use to look at caries. And it gives us a numerical reading. The higher the numerical reading, the more extensive or the deeper the caries is. And we found that also if we use Diagnosing on hypomineralized enamel, it will give us a similar reading. The higher the reading on Diagnosing, the weaker the enamel will be. So that is one safe method to look at MIH enamel and predict its severity. How about hypomineralized incisors? We've been talking about hypomineralized molars. How about hypomineralized incisors? How can we manage them? Can we bleach them? Can we do microabrasion? Should we always use composite veneers? Well, as pediatric dentists, we always try to be more conservative. We try to avoid, as much as we can, removal of enamel. Enamel is a really beautiful tissue that we try to conserve as much as we can. So one study in 2019 looked at microabrasion. So they used microabrasion, which is, I think we can all agree, more conservative than actually trying to remove the enamel, a layer of enamel, and put composite facing. So they did microabrasion, and in one group they kept on applying tooth mousse, and in another group they did not apply tooth mousse, and they compared the aesthetic results after 6 months. And as you can see obviously from this slide, the aesthetic results they got with microabrasion alone were not as good as with microabrasion and continuous treatment with tooth mousse. So if you're going to use microabrasion, please do use tooth mousse with it. I don't have many cases with microabrasion for MIH, but I have many cases with microabrasion for a similar hypomineralization, which is fluorosis. So I used to work in Riyadh, and Riyadh and the central region of Saudi Arabia has endemic fluorosis. And this is how more severe fluorosis look like. It looks like brown lesions in the facial surfaces of those incisors. So what we used to do with these teeth is we had our own protocol. We used to first, after looking at the shade, we used to treat them with microabrasion slurry, then bleach them with hydrogen peroxide and office bleaching, and then we get the beautiful results. So this is the before and this is after. Although after is quite chalky white, but it's still much better than, obviously, as you can see, the brown lesion. This is another case with really dark brown lesion that was treated with the same approach, microabrasion followed by hydrogen peroxide bleaching, and we got really nicer results. Uh, However, tooth whitening under 18 for those children who are under 18 is debatable. In the United States, the American Academy of Pediatric Dentistry developed their own guidelines for the use of bleaching in those kids. However, in the UK and in European countries, the use of hydrogen peroxide for bleaching is not allowed, which creates a little bit of a problem for us. Should for at least for those dentists, should they break those regulations and anyway go ahead and use bleaching, or should they use more invasive procedures? I'm not sure about Jordan's. I'm not sure if there are any rules to dictate that, but these are the international rules anyway. We can also use Ikon on those anterior teeth, and there are some reports to show us that they do give some improvement in the aesthetic results. And for Iman, because she already had some unsightly composites, we changed those composites into better ones, and Iman lived happily ever after. Now, we talked about small and moderate defects. How about larger defects? When the tooth is really buggered, how can we manage those cases? Should we think about extraction? Uh, I mean, given the complications associated with the restorative treatment and the burden of a lifelong restoration and probably repeat restorations, should we consider extraction for at least the more extensive cases, not the mild or the moderate cases, but for the severe cases? Well, this has always been a debatable issue between pediatric dentists and the more conservative dentists. And to put things into perspective, we have to look at what we know. So we know that sixes are rarely the orthodontist's first choice for extraction because of their location in the mouth, their posterior location, and because of the fact that they are mesiodistally quite wide, which means longer treatment time, and because they are really good teeth for anchorage, so they are rarely the orthodontist's first choice for extraction. We also know that if we extract the sixes at the time of the development of the roots of the sevens, we might get some good mesial drift for the sevens, and less distal drift for the fives. In other words, if we do the extraction for the sixes at the time of the calcification of the forcation of the sevens, we will hopefully get some good mesial drift for the sevens and less distal drift for the fives. And this is usually around the age of 8 or 10. Sorry, at the age of between 8 and 10. So this is an panoramic view from a study that was done in Sweden, and it shows us a child with severe MIH that presented at the age of 7 and 7 months. And then the furcations of the sevens were starting to develop. And later on, 5 months later, the sixes were extracted and the sevens were monitored in their mesial drift. So this is at the age of 8 and 8 months. The sevens started to erupt. And you can see that they are drifting mesially here. And close to the age of 18, they achieved some excellent contact between the sevens and the fives, as you can see here. The position is really nice, but it's not always the case. This is another case that was approached in a similar way, but as you can see here, there is some mesial tipping of the lower sevens. There is some gap between the sevens and the fives, and there is some distal drift of the fives, allowing a gap between the five and the four. So it's not as predictable as we would like it to be. So as I said, there are some Swedish studies that recommended extracting those severely hypomineralized sixes, and they present some good long follow-up with good outcomes. But they are small, they are done on small samples, and there are a lot of data that we would have liked to see that have not been reported. So again, back to our questions, what do we do when we are considering extractions? Should we extract or not? First of all, never ever extract without consulting an orthodontist. I never extract those first permanent molars without first consulting with an orthodontist. And the best time for extraction is not actually when the furcation starts to mineralize. We noticed from our experience at the University of Otago that if we could wait for the sevens to have half of their roots, or preferably even 2/3 of their roots developed before we extract the sixes, the results would be better. So instead of waiting just for the furcation to calcify, if we can just hold on for a little bit longer, we get better results. And we noticed that most of the upper sevens will achieve satisfactory contact with the fives, which is brilliant, but with a little bit of mesial-palatal rotation. For the lower sevens, it's a little bit harder. Probably half of them would only achieve satisfactory results. The other half will need some sort of uprighting. This is because probably the width of the lower sevens is a little bit wider than the uppers. The width of the lower sixes is wider than those of the upper sixes, and also because of the mesial inclination of the mandible. But always check for the presence of aids. We do not want to end up with short arches. Also look at the occlusion. If you have a class 1 occlusion, usually if done at the proper time, it's usually no problem. But when we have increased overjet, like in this case, the results would not be as good if we had to extract the lower sixes. So to be safe, just always consult with an orthodontist, and usually you can reach to the stage where either both of you or usually neither of you are happy with what's happening. We talked about first permanent molars, but we also know that unfortunately it can also affect the second primary molars and other primary teeth like the canines. And we know from experience and from multiple studies that the occurrence of such a case of hypomineralized E's is very frequent with hypomineralized sixes. Actually, 30% of hypomineralized sixes will have hypomineralized E's. And we are usually confronted by these cases in our practice where we see this hypomineralized E at the age of 4 or 5, and the mother will ask us, what are the chances of my child having MIH in their permanent molars? And this is always a difficult question to answer. Are the kids with hypomineralized E's more likely to develop MIH in their permanent molars? The answer is yes. They are actually 6 to 10 times more likely to develop MIH molars when compared with children without MIH E's. So the presence of hypomineralized E's can be considered as a predictor for hypomineralized sixes. In managing those hypomineralized E's, the same rules apply as in first permanent molars. With small defects, we can use composite. Bigger defects, we can use stainless steel crowns. But when we're talking about stainless steel crowns, we have to consider the whole crowns or the whole technique. And I'm sure all of you or many of you are familiar with the whole technique, but just a quick background. The whole technique is a technique that was developed by a general dental practitioner. Her name is Lorna Hall, and she used to live, or she still lives, in the northern part of Scotland. And what she did was the fact that she managed those caries, not necessarily hypomineralized E's, but caries first and second primary molars. She managed them without any sort of excavation, without any sort of local anesthesia, without drilling, without any preparation. She just basically chose the correct side of the stainless steel crown and placed it with her finger pressure or with the child biting forces on those carious molars, and she got some tremendous results. She had really good success with that. Uh, so this is a patient of mine, Joe, who presented with those deeply carious molars, and we thought, why not try whole crowns for him? He was quite uncooperative, so we couldn't drill properly, we couldn't excavate properly, and we managed to place the whole crowns, the stainless steel crowns, without any preparation. And these are Joe's molars 1 year later. As you can see, they look quite healthy. The gingiva around them is very nicely reacting, and he had no complications. And we know actually from multiple studies, the most famous of which is probably the Merest-Fairhurst studies, that sealing over caries does work. So we know that we can seal over caries. So much, in fact, that sometimes sealing over caries has higher success rate than actually trying to remove all the carious tissue. And um, the Professor Nicola Ennis from the University of Dundee is the person that who did the most extensive study on whole crowns. I'm proud to call her my friend, and she did randomized clinical trials on whole crowns to see how successful they are. So it was a big study, and a lot of general dental practitioners were involved, and they placed a lot of whole crowns on carious primary molars, and those molars were followed up for a number of years. So their approach was first. On the first visit, they placed separating elastic between the carious molar and the other molar, and they leave it there for a few days to open the contacts, as you can see here. Then they would choose the correct size and push it in with their finger pressure or with the child biting forces, and the end result would be like that, without any preparation, without any excavation. And they had really some tremendous success with that approach. In a 2 year follow up, they got 93%. After 5 years, they had a survival or success rate of 92%. This is really high. This is way, way higher than composite and than any other restorations that we are familiar with. So the use of stainless steel crowns or the whole crown works with primary molars, and it's being tested now nationwide in New Zealand by Dr. Dorothy Boyd and Dr. Foster Page, and hopefully we'll get some encouraging results soon. And although it has not really been tested in clinical trials on hypomineralized molars, there's absolutely no reason why we cannot use them on hypomineralized molars. I actually do use them, and I encourage you to use them when needed on hypomineralized primary molars without without any preparation if need be. I just want you to remember that behind those primary and permanent hypomineralized teeth, there are actual kids. Don't just look at the molars, look at those children. So these are all pictures of children that I've seen with hypomineralized molars, well, other than Kermit the Frog, obviously, but all of those are children that suffered with of MIH. And we know from research that the oral health related quality of life for those children is compromised. So don't just think about the tooth, think about the child, think about the family, think about their own preferences and what methods and what techniques you can use to help them. We talked about so many aspects of MIH, and which brings us to the main question, probably the question that remains on everyone's mind, which is why? Why does this amazingly destructive condition happen? Why do a lot of people have it? Is it something in our diet? Is it something that happened to those children when they were young that caused it? So far, the condition is idiopathic. Despite so many studies for the different etiological factors, we still do not know why this condition is happening. Many studies looked at respiratory illnesses, perinatal conditions, dioxins, oxygen deprivations, fevers, frequent childhood illnesses, even antibiotics. Some studies even looked at genetic polymorphism or genetic predisposition, and they all found inconclusive evidence that or inconclusive relation to MIH. So some of them or some of these factors that I mentioned might be related, some might not be related. So far, we cannot say without doubt what is the cause. And that made us think or pushed us to try to assess the cause of MIH in these teeth. But you can't just jump right away and try to study the cause. We had to think about it in a clever way. And the first thing we did was to look at the composition of MIH enamels. How is it different? And we did a lot of studies down under in Australia and New Zealand to look at the MIH enamel. I myself used scanning electron microscope to look at the enamel. And this is an 80,000 magnification of sound enamel. Look at those hydroxyapatite crystals. So what you see here is single separate hydroxyapatite crystals that are glued with proteins. Look how beautiful this architecture is. It's a well-engineered tissue, amazing structure that is compromised with MIH enamel. But I didn't have to look at that mineral phase a lot because there were other studies used chemical analysis, X-ray diffraction, ion mass spectrometry, and they all found that the mineral part is more or less normal hydroxyapatite crystals, probably with a little bit more carbonate. The only difference between the mineral part of sound enamel and of hypomineralized enamel is the fact that the hydroxyapatite crystals in hypomineralized enamel were not as densely packed as in sound enamel. So with MIH, the hydroxyapatite crystals are not as packed. But I looked at the organic part instead of the inorganic part. I looked at the organic part. And this is from what we call, if you remember your histology studies, this is an H&E study looking at the demineralized sections of sound enamel on your left and MIH enamel on your right. And you can clearly see that the organic matrix, so this is a demineralized section, which means we removed all the hydroxyapatite crystals, and all what we ended up with is the organic matrix. And you can clearly see that the organic matrix in those hypomineralized hypomineralized teeth is very thick. There is hardly any space for the crystals. Look at the one on the right and compare it to the one on the left, and you can see how much more spaces for crystals and prisms are available in the sound enamel as opposed to hypomineralized enamel. I took it one step further and I looked at the actual protein content of MIH enamel. So I wanted to see how much proteins MIH enamel had, and we used some complicated biochemical studies, and we found that hypomineralized enamel had on average 15 to 21 times more protein than sound enamel. That is a lot of proteins. If you remember your enamel composition, it's mostly crystals, a little bit of water, and a tiny, tiny amount of proteins. MIH enamel had on average 15 to 21 times more protein than sound enamel, and that is bloody a lot. We wanted to know what type of proteins the MIH enamel had, so we conducted some more biochemical analysis, and we did something called SDS, polyacrylamide gel electrophoresis. It's a lot of complicated things, but we noticed that the most abundant protein was a protein with the molecular weight of around 50 kilodalton, and that is basically serum albumin. The most abundant protein in MIH is serum albumin. Again, I repeat, this was an important finding. The most abundant protein in MIH enamel is serum albumin. This is very peculiar because in sound enamel, we don't see serum albumin. In sound enamel, we see enamel proteins, amylogenin, enamelin, but certainly not albumin. We also found some hemoglobin, some tissue injury and repair proteins, which is all peculiar. We don't see that in sound enamel. We don't even see that in amylogenesis imperfecta. In amylogenesis imperfecta, we see increased amylogenin, we see increased enamelin, but certainly not albumin and blood proteins. We found a lot of hemorrhage proteins, a lot of coagulation proteins, basically a lot of blood proteins, which is very, very strange. So we were interested to understand where those proteins come from. So we wanted to understand the pathogenesis of MIH enamel, how it is forming. So we took it one step further and we did some immunofluorescence. And this study is in press now at the Journal of Dental Research. Hopefully it will be published soon. What we did is we took some MIH molars, we sectioned them, and we mapped the distribution of blood proteins in MIH enamel, and we used something called confocal scanning lasers microscope. A lot of fancy names. Anyway, to cut a long story short, this is what we end up with. So basically, this is a section in an MIH molar. You can see the dentine on your left, and if you look carefully, you can see the dentinal tubules, and on the right is the enamel. When enamel and dentine, or hypomineralized enamel and dentine, when they are subjected to a certain wavelength of laser, they fluoresce. You can see them like a Christmas tree. Not all the enamel, just the hypomineralized part. If you remember that the cervical part is always sound, it will not fluoresce with when subjected to laser. So this is what we end up with. You can see a clear cut between the hypomineralized part of the enamel and the sound cervical part. If we look where the albumin is present in this enamel, we trace it with the color red, and you can see it here. It's spanning the entire thickness of the MIH lesion, but it's mostly concentrated at the deeper part of the enamel, close to the dentine enamel junction. If we try to trace the hemoglobin, we also find it spanning the entire thickness of the enamel, but mostly at the deeper part, close to the dentine enamel junction. So this was quite interesting. And it led us to think, where could this blood protein be coming from? A study from Melbourne suggested that these proteins could be coming from saliva. They are penetrating from saliva. Remember that this enamel is porous, so there is hemoglobin, there is albumin in saliva, and they might be gaining access into this enamel from the porosity and from the broken down part. Well, by mapping them, we saw that they are actually concentrated in the deeper part, which makes penetration from saliva unlikely. But we thought, okay, let's look at a salivary marker. Let's look at amylase. Is amylase present in MIH enamel? So we used the same technique and we tried to map the presence of amylase, salivary amylase, and we couldn't find any amylase in MIH enamel, which tells us that those proteins, hemoglobin and albumin and the hemorrhage proteins, are not reaching this MIH enamel from the saliva. So where could they be coming from? That made us look into the literature. What are similar cases? Are there any similar cases, any similar conditions that have such presence of albumin and hemoglobin in enamel? And that led us to look at the work of the hardworking, the amazing Grace Suckling, the late Grace Suckling, and the amazing work of Colin Robinson. We looked at their research, and we found some interesting findings. So this is a tooth. As you can see, these are two central incisors that developed or erupted after their predecessors received a trauma. So a child received a trauma when they were younger, probably 3 or 4, received a trauma to their primary incisors, and the primary incisors caused injury to the permanent incisors, and the permanent incisors developed like that, having this hypomineralized lesion. This hypomineralized lesion looks exactly the same like hypomineralized lesion in those MIH affected teeth. A study from Turkey delivered physical trauma to rat incisors while they are developing, and they noticed some blood leaking under the ameloblast into the developing enamel, as you can see here. And this was quite interesting. So blood can reach to the developing enamel, as we can see from this study and from the previous study, it can reach into developing enamel. So could MIH molars and incisors be the result of a trauma, a physical trauma? That was a peculiar thought, given the location of the molars way in the back of in the jaw. But we took one step back and we looked at what we know. We know that MIH molars have similar protein composition to traumatized teeth that we established. We also know that MIH affects only the first permanent molars and to a lesser extent incisors and second primary molars. We also know, this is important, that first permanent molars, the sixes, start to mineralize in their occlusal parts around birth time. So a molar, when it starts to mineralize, it starts at the occlusal level and then go down to reach its cervical part. And this mineralization usually starts around birth time. And if we look at MIH molars, we know that only the occlusal part is affected while the cervical part is not affected. We also know from the work of Colin Robinson, if you remember your histology, when teeth during their development, they go through the secretory stage and then they move into the maturation stage. We know that during the secretory stage, early enamel development, if an enamel is insulted, if there is a physical trauma, the secretory stage enamel is resistant to permanent damage. However, when it's in the maturation or mineralization stage, the enamel is not able to resist the permanent damage. To explain this a little bit more, this is enamel in its secretory stage, as you can see here. And the red part is the crystal part, and the blue is the protein matrix. Because of the presence of protein matrix around the crystals in the secretory stage, where it's mostly protein rather than crystal, any trauma will not allow the albumin or the hemoglobin to reach into those developing crystals because the enamel matrix protein, the amelogenin, the enamelin, protect those crystals from the albumin. In the maturation, in the transition stage, if there is a trauma, because most of the enamel protein matrix is gone, the a physical trauma will allow the albumin and the serum protein to reach to those crystals. If albumin or serum proteins are allowed to reach to those crystals, a catastrophic thing happens. They bind to those crystals firmly and prevent them from growing. So during the secretory stage, even if there was a physical trauma, albumin cannot reach the crystals, but in the transition, the maturation stage, and the mineralization stage, the albumin can reach to those developing crystals. And an important study by Prof. Colin Robinson from the University of Leeds found that if a physical trauma is delivered to cow molars, this is the end result. This is a cow's molar that received trauma while it's developing, and this is the end result. You can see that the occlusal part, which was going through the maturation stage during the trauma, is hypomineralized, while the cervical part that was going through the secretory stage during development, during the trauma, was not hypomineralized. And this looks exactly the same like our hypomineralized molars. The occlusal part is affected, while the cervical part is not affected. So that made us come up with a model for MIH pathogenesis. No, not this type of model. You wish it's this type of model, which is a complicated type of model. And is it some kind of physical trauma that affects the parts of the sexes that are mineralizing around birth time? Could it be the reason? And what kind of physical trauma could be the reason why MIH develop in this manner? What type of trauma that could happen around birth time? Because we know that the sexes mineralize in their occlusal part around birth time, while the cervical part is still not mineralizing. So this trauma, this physical trauma, will have to have come around birth time. But what kind of physical trauma could have come around birth time? Basically, it's birth itself. Passing through the birth canal is a traumatic thing for the child. So the narrow cervical canal can cause injury to the developing tissues, can cause bleeding into the developing tissues. And with the pressure of the cervical canal, probably with the pressure of the obstetrician's fingers, the forceps, that could all develop, will cause physical injury that is transmitted through the green stick bone of the baby. And all that physical injury can reach to those teeth that are developing around birth time, which are basically the first permanent molars, and to a lesser extent, probably the incisors and the second primary molars. If you remember this picture from my lecture yesterday, this is the picture of Yasmin, my niece, when she was first born, and you can see all that subcutaneous bleeding and subcutaneous ecchymosis. This is all bleeding because of the birth itself. It's actually so common that most hospitals worldwide do not record those traumas because it's so common. And funny enough, Yasmin now has MIH in her second primary molars. She's 5 now, and this is we see MIH in her second primary molars. So that lab study, that theory, which was proposed by our lab study, is only still a theory. We wanted to give it a little bit more support. So at the University of Otago, we were lucky to have the Dunedin Multidisciplinary Study. And what is the Dunedin Multidisciplinary Study? Basically, it's a prospective study. All those who were born at the city of Dunedin in New Zealand, where the University of Otago is, all of those who were born in 1975 are being followed up until now every year to assess their mental health, their physical health, and their dental oral health. So we were lucky to have this amount of information available to us. And we looked at the need of multidisciplinary study with our hypothesis that difficult birth can lead to MIH. And we looked at indicators or predictors of difficult birth. And we thought, could we prove that difficult birth is related to MIH? And we looked at those indicators of difficult birth. We looked at the birth weight. So we'd assume that the higher the birth weight, the more difficult the birth is. And we noticed that the higher the birth weight, the more likely the child would develop MIH. And if that child has MIH, the higher the birth weight, the more severe MIH is. We also looked at the head circumference. The bigger the head circumference, the more difficult the birth is, and the more likely the child will develop MIH. We looked at the birth order. The firstborn child will have to go through a more narrow cervix. The cervical canal will still be narrower. So the firstborn child will have more likelihood of having a difficult birth. And yes, it has more likelihood of developing MIH. We also looked at the gestational age. The longer the child stays in the womb, in the uterus, the more they will grow, and yes, the more likely they will develop MIH. And then we looked at the presence of more than one of those factors. We know that each one of those factors alone increases the likelihood of MIH, but would more of those one factor together increase the likelihood of developing MIH? And this is what we got. One factor increases the likelihood, two factors increases the likelihood more, three factors are more chances, and four factors, almost 100% the child will have MIH. So we were able to provide some more support to our findings. Then a good friend of mine, Dr. Ruhaida Abdul Halim, who is now in a university lecturer in Malaysia, did her doctorate study to look at the theory. So she did a matched case control study to investigate the factors around birth time that could be related to MIH. And she found some association with the length of labor with MIH. She also found some association with oxygen deprivation, fetal distress, and premature birth. She found some association with MIH. But because of the small sample number, the associations were not statistically significant, and that tells us that we need more studies. Although we are tempted to look at to consider MIH as caused by difficult birth, unfortunately, not all cases of MIH can be explained by difficult birth. We see MIH in premolars, we see it in canines, we see it in children that we are certain that they did not go through difficult birth. So difficult birth might be one of the reasons, but certainly not all of the cases of MIH can be explained by difficult birth. So we think that MIH is the end result of different etiological factors. So in summary, MIH is a significant problem that faces us, and it affects 1 in 6 kids worldwide. It causes increased sensitivity, and it's a really poses a big problem in restorations. In big defects, extracoronial restorations may be recommended. We might consider extractions in difficult cases after consultation with orthodontists. And in addition to other possible causes, difficult birth might be the cause behind MIH. This is a book that I highly recommend you to read about different developmental dental defects, especially chapter number 6 because it's written by me and by my friend Erin Mahoney. So if if you wanted a resource to read, this is an excellent resource about developmental dental defects. And please go and look at our website, the D3 group website, and please do join us. We need your support to keep our research and our work on developmental dental defects going. And thank you all for listening. And thank you, Jazz, for making this possible. I miss you all and wish you all the best. And hopefully, we can get together again and see you all soon. And I can open the doors for questions now. Let me see if there are any questions. There were a few questions yesterday that I answered directly. So if you're interested, there will be a few questions that were answered on the Jazz Facebook page. Well, okay, I think there are questions. So let's see. Brian is asking, one, no cement is used under crowns of whole technique. No, there are cements. First, we try the sites and we use glass armor cement. And the second question, the survival of composite with MIH incisors. That was what we addressed yesterday. They have a lot of failures, but if done properly, if the case was chosen properly, they should have a similar success rate to those for dental caries. Three, how to differentiate fluorosis and MIH? Well, fluorosis usually affect all the teeth, and it's what we call diffuse hypomineralization, not well demarcated. MIH usually affects the first permanent molars only, and to a lesser extent, the incisors. Fluorosis is not as common as MIH, and it is endemic in certain parts of the world, but the key feature is it being diffused. You mentioned MIH in premolars and canines. Yes, unfortunately, that is true. We more and more we are noticing it in second permanent molars, in permanent canines, in premolars. So we don't know what's going on, to be honest. So that poses a lot of questions. Yeah, you're right. We are noticing it more and more. Another question, why do you recommend total etch than self-etch in composite? Just because they're more highly successful. Research has shown that for some reason, if we use etch, rinse, then adhesive, the success rate is much, much higher than those self-etching adhesives. So with that, I would certainly recommend the etchant and separate steps for etching and adhesives. Let's see. Any more questions? Oh, well, thank you all for your kind comments, and thank you for all for tuning in, and good luck, guys. And again, for those of you who are still interested to join us in our next literature review session, it will be on basically fillings in primary teeth, and I will send you all the literature very soon. Take care, everybody, and best of luck.